Yeah, hello. Am I audible? Yeah, am I audible? Sharon, am I audible?
Yes, sir, you're audible.
Hello?
Yeah, Sharon.
Yes, you are audible. Am I audible?
Yes, you're audible.
Yeah, you're audible.
Excuse me, ma'am.
Yes, ma'am.
Ma'am, my video is not working actually.
Yes, ma'am. Sorry, ma'am.
I'm
Hello.
not able to display my video actually.
Display your video, ma'am. You can rejoin again. You can leave the meeting and rejoin again. If there is a technical glitch, then you can rejoin. Then your video will be visible.
Okay,
Or
I'll try again.
yes, ma'am. Yes. Dr. Shalin Amir, ma'am, your voice is cracking, ma'am.
Okay, am I visible now?
No, ma'am, you are not visible, ma'am. Do one thing, ma'am. You can stop your video.
Okay.
You can stop your video. I'm sending a request option. Just click on that. Okay, to start your video, I'm giving you a request. Click on that. You can stop your video now.
Okay.
Done, ma'am. Okay. Is there any option popping on your screen, ma'am?
Yes.
Okay. Select on that, ma'am.
I selected am I visible?
No, ma'am. Still, you are not visible, ma'am.
Check.
Dr. Shalin Amir, ma'am, your I think there is a network issue with your system actually because your voice is also cracking, ma'am.
Is it clear now?
It's perfect now, ma'am. But the video is not visible, ma'am.
Yeah, I'm working on it. I don't know what to do. My videos are working.
A little voice cracking still, ma'am. There is still persistence of voice cracking, ma'am.
Okay, so what shall I do with the video? It's not working.
Not working. Let me just check out. Is there any options popping on your screen, ma'am?
Yeah, I've clicked on it again, but still It's not.
It's not visible, ma'am.
Yeah, it's not visible.
Oh.
Hello.
Hello, sir.
I thought I'm audible, no?
Hello, sir. Good evening, sir. Yes, you are audible, sir.
Hello, sir. I'm Ankita from Planet, sir. I'm the assigned moderator for today's session. So, sir, to whom will I be handing over the session, sir?
Okay. Everything is fine, no? Video, everything is fine.
Yes, sir. It's absolutely fine.
Okay, Praveen, okay.
Yeah.
Sir, to whom
So-
will I hand over the session, sir?
So, Ankita, I will be handing over the session to Mr. Jay Vignesh.
Sorry,
Sir,
sir.
good morning, sir.
Jay Vignesh, switch on your video, please.
Okay, okay,
Sir,
sir.
good morning, sir.
Good morning.
Yes.
We can start the session. Now, how long this session is?
Sir, for an hour, sir. For an hour. From 6 to 7.
Sir, it's
Sir.
for an hour, sir.
Okay.
Sir, shall we start the session, sir?
Another few minutes. Another 5 minutes.
Yeah, okay.
Yeah.
Students having any doubts will be coming in which place?
Sir, at the end of the session,
You
the
will
moderator will be telling us, sir.
Okay.
Yes,
Sir, I mean, doubts, you mean to ask from
If
which
they
place
have,
all of them?
if they have any doubts,
Yes, sure, sir.
okay.
Sir,
If they have
they
any
are
doubts,
displayed in the
you
chat.
coordinate them. Yeah, you
Yes,
coordinate.
Okay. Sir, shall we start in 2 minutes, sir?
Yeah, I am ready.
Shall we start?
Whenever you want, we can
Yes,
start.
sir. Okay, sir. People are joining, sir. That's right.
Yeah, okay.
In 2 minutes. Yes, sir. Thank you, sir.
Hello, Ankita? Ankita? Hello?
I think she's muted.
Yeah, you can start, Javignesh.
Yeah, sir. Once again, Shalin is joining, sir.
Yeah.
When she joins, we start. Yes, sir. Sir, shall I start this? Shall I start the session?
Yeah,
Yeah,
yes.
go ahead. Go ahead.
Good evening, everybody. A warm welcome to all to the session.
Sorry to
So-
interrupt you, sir.
Yes, sure.
Sir, the meeting was
Yeah.
scheduled at 6. So, will we start now, sir?
Yes, we will start now.
Yeah, we can start. We can start.
Oh, okay, sir. Just give me 2 minutes to introduce you all.
Yeah, yes, ma'am. Sure, we can.
Good evening and welcome to one and all present in this session. I'm Ankita from Planet. Planet is very proud to be a part of this webinar as a digital partner. Now, I would like to present you all a short video of Planet. Thank you so much for all of your patience. Planet is India's largest live digital CME and doctors generated medical content platform. Our website is www.planet.com, where we have lots of live sessions conducted by eminent speakers across the globe. We have made wiki services, which is medical Wikipedia for doctors only, that also you can read in your leisure time. We would invite all the doctors to visit our website. Now, without any further delay, I would like to hand over the session to Dr. Jaya Vijay. Over to you, sir. Thank you.
So thank you, ma'am, for your intro. Shall we start the session, sir?
Yeah, we can start.
Go ahead.
Yes, sir. Good evening, everybody. For all those who are present here for this very good webinar. So, introducing myself, I am V.L. Javignesh Raj, State Assistant of Medical Education Unit Team, Student Network Organization, and also I'm doing my pre-final year MBBS in Government Villupuram Medical College and Hospital, sir. I'm studying in your college, sir. So I'm very I feel so proud to host this webinar, sir. So. Yes, Shalin, please.
And I'm Shalin, sir. I'm also doing my pre-final year from Villupuram Medical College, and I'm the State Research General Assistant.
Very good, sir. Great to hear.
Sir, so I really feel elated to see the medical students from all over the world. Like there are many doctors to join this webinar. I hope this will be a very interesting session as well. So IMA JDN and Student Network Organization has been doing a lot of webinar on various topics with an objective of disseminating knowledge about various topics. So this time the IMA JDN in collaboration with Student Network Organization presents you with a webinar on the topic Obstructive Jaundice and its surgical intervention and its management, sir. So in this
I think Jai Vignesh is from hostel. No signal will be there. He got stuck up.
Raja Mahendran Rajan, assistant. So Shalin, can you read out his?
Hello, Venkatesh.
Shalin.
Good evening, sir. How are you, sir?
Fine, Venkatesh. I hope you are traveling somewhere.
Yes, sir. Traveling somewhere. Thank you, sir.
Thank you.
உங்க பேரை பார்த்தாலே எல்லாரும் பயங்கரமா ரெஜிஸ்டர் பண்றாங்க. 3000 plus registrations actually.
3000, yes, sir. Actually, I informed sir, Venkatesh sir. I told sir that around 3,000, more than 3,000 people have registered for this webinar.
Yes, sir. Just for the name of sir, actually. So the same level of promotion we did, sir. But just for attending your session, people are very eager. Thank you so much, sir. You know how much busy you are.
Thank you, Pa.
Okay, sir. Thank you, sir.
Thank you for giving me the opportunity for a session. Shall I start?
Yes, sir. Yes, sir. You can start, sir. You can start.
Thank you all. Start the session. So I go for screen sharing. Hope I'm fine. Good evening, friends. Today we're going to discuss one of the important topics. It's an obstructive jaundice, the clinical approach for an obstructive jaundice. It's a very important topic for MBBS students, especially final years. This will be a long case. This contents of this topic can come for you as various short notes. So we're going to evaluate obstructive jaundice in detail. But before going to the evaluation of obstructive jaundice, let us see what is meant by obstructive jaundice. Let us first of all discuss what is obstructive jaundice. So to know about obstructive jaundice, I request you all please understand the basic anatomy. The basic anatomy of bile duct. This is right hepatic duct, this is left hepatic duct, and this is common bile duct. Okay, this is a common bile duct. So the common bile duct is divided into, this is common hepatic duct and this is common bile duct. Okay, common hepatic duct is 2.5 centimeter, common bile duct is 7.5 centimeter. So no surgery question is there without knowing the anatomy. So you have to know the basic anatomy. And this is the liver. From liver, we have multiple biliary canaliculi which will produce bile. All this will drain into the bile duct. So all this will join and form right duct and left duct that will allow the bile to flow down like this. So this is how the bile is flowing down like this. As the bile is coming down, you should not forget they all get concentrated in the gallbladder. So the gallbladder, the bile gets collected in the gallbladder and they get concentration. So there is a concentration of bile happening. The concentration is 10 times concentration happens. So whatever the water in that will be absorbed. So there will be high concentration of the bile which is happening in the gallbladder. And after that, the concentrated bile only will come out of the gallbladder into the bile duct, and it is now opening into the duodenum, which is guarded by ampulla of water. Okay, so ampulla of water, it is going to open at the level of ampulla of water, and it is guarded by a sphincter known as sphincter of OD. Okay, sphincter of OD is there, which is a very, very important sphincter, which is made up of 4 complex sphincters. Sphincter of OD is not single sphincter, it is made up of 4 complex sphincters. So it is present here. This common bile duct, before joining the ampulla, it will be joined by another duct, that is pancreatic duct. Please remember, this is pancreatic duct. So pancreatic duct and common bile duct will open into the sphincter of OD and will open into the second part of duodenum. So this is the basic anatomy you would have read in your second MBBS days. So please understand, bile is produced from the liver. Bile is a very important substance because it is carrying cholesterol, bile salts, etc., etc. All the excretory products of liver, like kidney excreting urine, the excretory products of liver is also by means of this bile duct. So everything is carried in this bile duct and going down. So what is mean by obstructive jaundice? Obstructive jaundice is also known as surgical jaundice. So because we call it as a surgical jaundice. So there are many types of jaundice you all will be reading in medicine, like medical jaundice includes hepatocellular jaundice and various viral hepatitis causing jaundice. All those things I'm not going to discuss. I am going to discuss jaundice which can be cured by surgery, and that is called as obstructive . Cause of obstructive jaundice, the congenital causes are: number 1, extrahepatic biliary atresia; number 2, choledochal cyst. So these are congenital pathologies. So extrahepatic biliary atresia and choledochal cyst, which you will be reading in pediatrics, but we can cure both the conditions by surgery. So extrahepatic biliary atresia is nothing but the bile duct outside the liver is fully atresia. There is no flow further. The bile duct is not developed. That is known as EHBA. Choledochal cyst is abnormal dilatation of bile duct. That is also going to cause jaundice. So this is congenital causes of jaundice. Inflammatory causes. There are so many inflammatory causes which can cause this problem. This is known as cholangitis. Number 1, cholangitis. Cholangitis is an inflammation of the bile duct. It may be due to any reason, but cholangitis can cause obstructive jaundice. Number 2, there is a disease, primary sclerosing cholangitis. The first one I told you is ascending cholangitis. Ascending cholangitis is infection ascending from the duodenum level, from the bacteria in the duodenum enters the bile duct. That is known as ascending cholangitis. Primary sclerosing cholangitis is a condition seen associated with ulcerative colitis and Crohn's disease. So it is an acquired condition, but it is associated with ulcerative colitis and Crohn's disease. There is a sclerosis of the bile duct that causes inflammatory cause. All these are very rare cause. What is common cause? So please remember the 2 common causes you should not forget are the benign causes of obstructive jaundice and malignant causes of obstructive jaundice. Let me divide them into 2. Benign causes, malignant causes. What are the benign causes of obstructive jaundice? Just you can think very common is a stone from the gallbladder from here is gone and getting obstructed in the bile duct. That is the most common benign cause known as CBD stone. CBD stone is a common benign cause. What are the malignant causes? Common malignant cause. Any cancer along the bile duct, like bile duct cancer. So there is a cancer in the ampulla known as periampullary cancer, head of pancreas cancer. So any cancer occluding, so bile duct cancer, cancer head of pancreas, periampullary cancer. So any cancer can occlude the lumen and cause malignant cause of jaundice. Other benign causes are very rare. You can know bile duct stricture following a cholecystectomy. When we injure the bile duct, that goes for stricture. Bile duct strictures is another benign cause. Any worms like hydatid or ascaris causing obstruction of the lumen. Along the lumen, there is obstruction by hydatid or ascaris. That is another benign cause. So there are many other causes like benign causes. We can list out, keep on moving on. Very lot of causes, but please remember these causes: CBD stone, bile duct stricture, ascaris, and hydatid. So malignant causes are bile duct cancer, cancer head of pancreas, and periampullary cancer. And there is another cause, that is there is nothing inside the bile duct. Bile duct is normal. There is some pathology outside that is causing compression of the bile duct. Pathology outside compressing the bile duct. So extrinsic pathology. So this doesn't need an explanation. Anything outside, like a cancer in the stomach, big cancer in the stomach can occlude the bile duct. A cancer in the gallbladder, please remember, a cancer in the gallbladder can compress the bile duct. Okay, or nodes. Any metastatic nodes in the level of hilum can compress. So extrinsic pathology. So any extrinsic pathology, something from outside can compress the bile duct. So whatever it is, when a patient gets obstructive jaundice, so obstructive jaundice, what is the clinical feature the patient will come to you? Obstructive jaundice clinical features. So please don't forget, the obstructive jaundice is going to cause so many important clinical features. These patients will have increased increased conjugated bilirubin. Increased conjugated bilirubin in the blood. In blood, please remember, the bile which has to be coming into the duodenum is now entering the blood because of the obstruction. See, this is the liver. Please understand the basic pathophysiology. Without understanding the basic pathophysiology, you cannot understand managements. For example, there is a cancer here. So I told you the liver is producing the bile, and that bile is going to come out in the bile duct. That is going to come out in the bile duct. So that is carrying the conjugated bilirubin, also known as direct bilirubin. So direct bilirubin is going to come out, will be usually coming out. So I hope you all know the biochemistry. So it is indirect bilirubin, which is produced from the hemolysis of RBC. The indirect bilirubin is getting converted in the liver, is carried to the liver and getting converted in the liver to direct bilirubin or conjugated bilirubin by UDP glucuronide. So this is a normal biochemistry you'll be knowing. So now what happens? The direct bilirubin that is produced, there is no issue in that. But what happens, because of the obstruction here, the direct bilirubin could not enter the lumen of the bowel. So it will start entering inside the liver, into the blood vessels, into the sinusoids. So therefore, what happens? There is increased conjugated bilirubin in the blood. So increased conjugated bilirubin in the blood will cause, very important, jaundice. Jaundice means what? Deposition of bile in the sclera. In the eyes, you can get deposition of bile in the sclera. You can see urine getting colored. Urine is high colored because the bilirubin is coming in the urine, secreting from the circulation. So the blood is having high bilirubin that is going to the kidney. Kidney is excreting the bilirubin. So there is urine colored, high colored urine. Yellow sclera, itching. Why there is itching for these guys? The bilirubin which is coming into the blood will deposit in the skin and that will cause itching. It will cause itching because of the bilirubin pigmentation can cause scratching all over the body. So itching. And very important, since bilirubin is not entering the GIT, so what is becoming white? The stools are not in yellow color. These guys have a clay color stools. Clay color or pale white color. We call it as white stools. Or clay color stools are seen in these patients. So when you ask history of jaundice, you should ask history of jaundice along with the yellow colored urine. They will have itching, clay colored stools. All these features will be present in an obstructive jaundice. Please remember, these are features of obstructive jaundice. Obstructive jaundice means they will have yellow colored urine, pale clay colored stools. Please don't forget this basic point. Without a clay colored stool, it is not obstructive jaundice. The stools, if it is yellow color, it cannot be an obstructive jaundice. Very interesting point. If the stool is becoming yellow color, how can you call it as an obstructive jaundice? Because the bile is joining the stool. So you cannot get a yellow stool unless it is a partial obstruction. If it is a partial obstruction, you can get on and off yellow stools, but mostly they have clay color stools. Very interesting point. So the very important cardinal features are jaundice present in the sclera, under surface of tongue, everywhere in the body you can have yellowish tinge. Urine colored, high colored urine, yellow color, itching is present and clay color stools are seen. Very interesting point. You should not forget all these findings are seen in this obstructive jaundice patients. So obstructive jaundice patients, when you are going to examine the abdomen, only one finding is very important, that is Courvoisier law. So without knowing Courvoisier law, the obstructive jaundice case is not completed in any examination. Whatever exam you apply for, you will be asked about obstructive jaundice and Courvoisier law. So what is Courvoisier law? Please understand the basics of Courvoisier law. This is right duct, this is left duct, and this is the bile duct. If there is an obstruction caused by stone here, if there is an obstruction caused by stone in the bile duct, where is this stone come from? The stone is coming from the gallbladder. So this stone has come from the gallbladder into the bile duct. Please remember, this stone has come from the gallbladder. Therefore, if there is an obstruction by the stone, the gallbladder already is a thickened chronic cholecystic gallbladder. So the wall is very thick. So wall is thick, therefore it cannot expand further. If there is an obstruction happening due to jaundice, the gallbladder cannot be expanding. So this is, if the obstructive jaundice is due to stone, gallbladder is not palpable. That is the point. Gallbladder is not palpable. See, another condition, if the jaundice is due to some cancer here, like a periampullary cancer or head of pancreas cancer, I told you gallbladder can enlarge up to 50 times because the bile which is coming, no, it will get regurgitated back and they will be occupied in the gallbladder. So 50 times enlargement of gallbladder, and it is a differential diagnosis of right iliac fossa mass. Please remember, it can go such a low down and it can present as a mass in the right iliac fossa. So if it is a cancer, gallbladder is palpable because it is a normal gallbladder. So it can enlarge. Even there is an obstruction, the fluid can accumulate in the gallbladder. So gallbladder is palpable. And in a cancer, gallbladder is not palpable in a stone. Gallbladder is not palpable in a stone disease. Gallbladder is palpable in a cancer disease. This is a Courvoisier law. Telling this, Courvoisier has gone. He died and he disappeared. But our people found out some exceptions to Courvoisier law. What is exceptions? Sir, it is a stone, but gallbladder is palpable. When is it possible? Gallbladder is palpable in presence of stone as there is one stone in the bile duct, another stone in the cystic duct known as double impacted stone. See, double impacted stone will cause enlargement of the gallbladder due to formation of mucocele. So there is a double impacted stone causing dilatation of the gallbladder known as mucocele. Please don't forget this point. Gallbladder is not palpable, is usual routine. But if there is a double impacted stone, gallbladder is palpable. So stone disease, when is gallbladder palpable? Means two stones, one in the bile duct, another in the cystic duct. So then another question is, a cancer, when will you say a cancer, but it is not, gallbladder is not palpable? That is another exception. When there is a cancer, what is the exception? When the cancer is here, what is the name of this cancer? This cancer is known as Klatskin tumor. So it will cause obstructive jaundice. Cancer in the hilum, known as Klatskin tumor, can cause obstructive jaundice. In such case, the bile will not flow down. There is no enlarged gallbladder. So the answer, second exception is Klatskin tumor. So actual two exceptions are these two. Other exceptions are not accepted exceptions. So only you should remember these two. So what are the Kurvaisier law? What is Kurvaisier law? What is the exception and what is non-exception? So please remember. So Kurvaisier law, if it is stone, gallbladder not palpable. If it is cancer, gallbladder is palpable. Telling this, Kurvaisier died. And after a few years, our people found out two exceptional causes. One is double impacted stone causing mucocele and Klatskin tumor causing no palpable gallbladder, no GB palpable. This is known as Kurvaisier law. Please don't forget Kurvaisier law. This is a high yield topic for your exam. So Kurvaisier law will be definitely asked in your exam. And what are the other things you should see in a clinical examination? So let me show you. This is a various things you should see in a clinical examination. So you should see eyes having jaundice. Very important. You should see for this is what is this? What is this finding? In an obstructive jaundice patient, they might have this finding. What is it? It is local native treatment. These are native treatment. You can see people having a native treatment like this, having that heat will be kept on the body. So many movies and all you would see, like native medicine treatments, like these are native medicine treatment. Can you see this is one of my patient having they will put some hot iron so that they will think that these are all will cure the jaundice. Like that they will have native treatment. You can see this guy having a native treatment of heat being applied on the arms. So obstructive jaundice patients, especially in the rural practice, they'll have native treatment being done. So you should note that. And you should examine for yellowness in the eyeball. Not actually in this place, you should actually examine the under surface of tongue. You should examine the body for scratch marks. I told they will have itching. So because of continuous itching, they will have scratch marks all over the body. And because of continuous scratching, if you see the nails will be shiny. So because of continuous rubbing, the nails which is rough will become shiny nails. So shiny nails are seen in obstructive jaundice patients. So please remember, these are the very important clinical findings. What are the things you should see in an obstructive jaundice from head to foot? Conjunctiva jaundice, oral cavity jaundice on the undersurface of tongue, tails, you should look for loss of shininess. In the trunk and extremities, look for scratch marks. On perrectal examination, you should look for clay-colored stools. All these are examination features you should not miss in an obstructive jaundice. I'll tell you finally, if you're going to get an obstructive jaundice, it is one of the easiest case to pass in the exam. Definitely the examiners will be very happy if you are going to tell few points, especially the interesting points like this, we are going to tell, you are definitely going to pass in an obstructive jaundice. So these are the clinical features. And one interesting history you should not forget in obstructive jaundice is associated features. When an obstructive jaundice patient comes to you, they can have the following associated features like whether they have pain or they are painless, whether they have pain or no pain. First point you should ask about it. Whether the jaundice is associated with any pain in the right hypochondrium, painful or painless. Then you should ask whether the patient is having fever or no fever. Whether they are having fever or no fever, you should ask. And you should ask about any malignant features, malignant history you should ask. Malignant history, you know very well, means what? Weight loss, loss of appetite. Okay, weight loss, loss of appetite, and other features of malignancy like cachexia you can observe from the patient. All these things you should ask. Pain. What is the reason for jaundice causing pain? Pain in a jaundice patient is usually due to stone disease. Please remember, it is usually a stone disease will cause pains. A gallstone will cause gallstone pain because from there only it has entered the bile duct, so there will be pain. Painless is usually a feature of cancer. This is not always, it is a feature of cancer. So please remember, pain is a feature of stone, painless is a feature of cancer. It is not compulsory. Sometimes like Klatskin tumor will have, Klatskin tumor might have pain because of the nerve infiltration. So the pericholectal nerve infiltration, pain may be present. Okay. Fever. What about fever? Fever is a feature of ascending cholangitis. Whenever there is a fever in a jaundice patient, you should be more aggressive because ascending cholangitis has happened. The bile is a culture medium for bacteria. Just remember, if one bacteria enters the bile, it will multiply like anything and it will cause ascending cholangitis, characterized by very favorite question. No Viva exam ends without asking what is Charcot striate. An obstructive jaundice patient with the Charcot striate. What are the features of Charcot striate? Pain, jaundice, fever. Pain, jaundice, fever. These three are present intermittently is known as Charcot striate. Intermittent pain, intermittent jaundice, intermittent fever is known as Charcot striate. You have, this case will not be kept for your exam because it's an emergency. They won't keep this exam case. Therefore, such cases you should immediately admit them and you have to treat them. Otherwise, they will go for septic shock and mental changes. What is it known as? Mental changes. This 5 features together is known as Reynolds pented. Very, very dangerous problem. So Reynolds pented happens if you are not going to treat them immediately. Reynolds pented has 50% mortality. So you should know how serious it is. So if you are going to have a Reynolds pented, it is going to have 50% mortality. So be serious with this case of Reynolds pented. So please remember, fever is a feature of emergency. Fever is an emergency feature. You should ask about it. And in the history, there is one more important history. So very important history. This question is again always asked in the Viva. They will definitely ask you this. Where will you get painless intermittent jaundice? Definitely this question is expected for you in the Viva exam. So in which condition of obstructive jaundice you will get painless intermittent jaundice? I'm telling you guys, if you're reading this obstructive jaundice case now, today itself, you should open your medicine book. Either you are a clinical book of Arup Kumar Gundu or Hutchinson and read medical jaundice now itself. Then only you will not have a confusion between these two. So I'm discussing only surgical obstructive jaundice. I'm not discussing medical jaundice. Medical jaundice is an exam case for you again. It is a medical case. So painless obstructive intermittent jaundice is because of this cancer known as periampullary cancer. Periampullary cancer is a cancer within the ampulla within 2 centimeters. So when periampullary cancer happens, it will grow like this and it will occlude the lumen. But after some time, what happens? This will fall down. Please remember, this will slough out. This tumor will slough out and suddenly the jaundice gets relieved. Suddenly the jaundice gets relieved. Again, the tumor will grow. Again, they will get a jaundice. So this is classical feature of periampullary cancer known as painless intermittent jaundice. These patients will have Thomas sign. What is Thomas sign? Thomas sign is nothing but I told you there will be clay color stools in all patients of obstructive jaundice. When there is a sloughing of tumor, there will be minimal bleeding. When it mixes with that bleeding, blood, melena, these two together will produce a type of stool known as silver stool. Silver color stool. The motion will look like a silver color stool. That is what we call it as Thomas sign. Stool is looking like a silver, shining silver, it will look like. So clay color stool, silver stool, 2 things are there. When a clay color stool mixes with melena, it is silver color stool. So at the end of clinical examination, you should be able to tell what is the case. So you should be able to tell the diagnosis of obstructive jaundice like this. So this is a case of obstructive jaundice. Obstructive jaundice. Obstruction at the level of dash. Where is the obstruction? At the level of, there are multiple levels. Now you see, you know very well, the level of common hepatic duct or common bile duct or periampullary, like that you should tell. So at the level of dash, due to dash. So this is what you should tell. So you should know what is the reason for this. Is a case of obstructive jaundice. Obstruction at the level of lower CBD due to CBD stone, like that you should tell. CBD stone at lower CBD probably. Okay, lower CBD, like that you should tell where the obstruction might be. You can give we can give it as a random diagnosis. Very examiner will be expecting you whether you are telling stone or cancer, which is purely based on Purvaisir law. So Purvaisir law says where is the obstruction? What is the cause of obstruction? If it is a stone, gallbladder will not be palpable. If it is a cancer, gallbladder will be palpable. Please remember this point for your exam. So this is very important. Painful jaundice with fever is CBD stone. Painful jaundice with fever is because of CBD stone. Painful jaundice progressive is hilar cholangiocarcinoma, Klatskin tumor. Jaundice with the back pain, pancreatic cancer. Whenever a back pain word comes, it is because of pancreatic cancer. Painless intermittent jaundice is periampullary cancer. So these are the 4 cases which can be kept for your exam. So the only 4 cases will be these 4. So you should therefore know about these 4 cases for your exam. So this is a medical jaundice. So you should always see whether this can be a medical jaundice. If it is a medical jaundice, very basic point you should not forget, medical jaundice patients will be due to cirrhosis. Cirrhosis is always associated with ascites and portal hypertension features. So a case of medical jaundice may be suspected on examination if a patient is having ascites with the features of portal hypertension. This you will be reading in medicine. And you should also see for dilated veins. You can see this dilated veins on the abdomen wall. Like this implies there is a case of Budd-Chiari syndrome. This can be a case of medical jaundice due to Budd-Chiari syndrome. Budd-Chiari syndrome patients will have dilated veins on the abdominal wall. I'm just telling you so that you will read medicine books and you see what are the causes of medical jaundice. Okay. So this left supraclavicular node is a very important finding, because if it is a cancer, they will have a left supraclavicular node known as Virchow's node. Virchow's node, and this sign is known as Treisier sign. The sign of enlargement of left supraclavicular node is Treisier sign. So please don't miss these findings if you are examining an abdomen case. Okay. And a patient coming to you with obstructive jaundice, there is a scar like this. What is this scar? Patient having a scar on the abdomen is history of previous surgery. He has undergone some previous surgery. Previous surgery, probably a cholecystectomy was done. At that time, they might have injured the bile duct. That is the cause of jaundice. This is known as bile duct strictures. This is known as bile duct stricture is a cause of obstructive jaundice. So bile duct stricture can be got from a clue of scar on the abdomen. Okay, you should see everything seen. So now palpable gallbladder, you can see there's a right iliac fossa. This is a hypochondrium. You can see gallbladder is coming up to the right iliac fossa. This is gallbladder. So this is a patient having gallbladder enlargement. It's due to cancer. Cancer is a cause of enlarged gallbladder. According to Purvaisier law, you can see this is one of our patients we are operating. You can see the enlarged gallbladder, very large distended gallbladder, because patient is having a cancer in the distal end. Okay. So this is a picture of showing you perrectal examination. What is the inference of perrectal examination? Perrectal examination will show you clay color stools like this. This is a clay color stool because no bile enters the GIT. No bile enters GIT. So the bile is not entering the GIT, causes clay color stools. So this is the sign I told you. You can see this stool is looking like a silver color. Silver color stools known as Thomas sign. So this is Thomas sign seen in patients of periampullary cancer. So please never ever forget what is Charcot-Stead and what is Reynolds-Pentet. They will definitely ask you Charcot-Stead and Reynolds-Pentet during the Viva discussion. What is mean by Charcot-Stead? What is mean by Reynolds-Pentet? Definitely they will ask you. Without knowing Purvaisier law, this topic never ends. So when there is a stone, there is no gallbladder. When there is a cancer, gallbladder is enlarged due to distension by the gallbladder. Up to 50 times it can enlarge. Please remember. Because it's an elastic organ, it can accumulate bile and can enlarge up to 50 times. Okay, so this is one of the patient I told you, double impacted stone. See this patient having a stone here, another stone here. So when we are operating, we got a gallbladder which is having only pure fluid. You can see this is not bile. Inside the gallbladder, there is pure clear fluid known as mucocele. It is because of the intrinsic secretion of the gallbladder. It is not bile. We call it as white bile. White bile inside the gallbladder is nothing but mucocele of gallbladder. It is from the secretion of the cells inside the gallbladder. There are some cells known as mucoprotein secreting cells which are inside the neck of gallbladder. They will secrete because of obstruction. They are unable to drain. So gallbladder becomes enlarged because of mucocele, double impacted stones. So systemic examination, what are things you should not forget? You should see signs of liver failure. You should always rule out this is not a case of medical jaundice. By seeing signs of liver failure, you will be knowing this in medicine like gynecomastia, pedal edema, ascites, splenomegaly. All those things will be seen in a case of portal hypertension causing medical jaundice. Scratch marks, ecchymosis, distendments, all these things you have to examine in an obstructive jaundice patient, and you have to give a final diagnosis of obstructive jaundice. site of obstruction and the cause of obstruction due to. This is very important thing. You should not forget. So now, what is the complication of obstructive jaundice? Why you should be very much worried about obstructive jaundice? What is the dangerous complication? Complications of obstructive jaundice, because without knowing the complication, we cannot discuss further. See, very important point here is the liver is excreting the toxic products. Please remember that liver is excreting the toxic products in the bile. Not only toxic products, it is producing one important essential substance for our body known as bile salts. Bile salts, again a biochemistry question, ursodeoxycholic acid, quinodeoxycholic acid, all these are produced from the liver and they are going to come into the duodenum. And in the duodenum, what they are going to do? These bile salts, what they are going to do inside? So liver is producing bile salts that is entering the duodenum, and the bile salts play a major role in the digestion of dash. Please never ever forget, digestion of fat is because of bile salts. By formation of micelle formation, etc., etc. There are so many points. Bile salt you have to read in biochemistry. That is what, when next exam is going to come, they are not going to ask you questions from biochemistry. They will ask you applied biochemistry question like this. So bile salts, what is the function of bile salts? What are the types of bile salts? Like that, this is where you have to open your biochemistry book and read retrograde. So when you go into read like that, retrograde, applied surgical topics will be very easy. Okay, you have to know about, now you have to read about bile salt anatomy, bile salt physiology, how is it produced, how is it excreted, etc. How does it prevent formation of cholesterol stone? Bile salts prevent formation of cholesterol stone. It is essential for digestion of fat. And what are fat? ADEK is a fat soluble vitamin. Please remember, it is a fat soluble vitamin. So when there is no bile salt entering the duodenum, patients will have ADEK deficiency. In this very important vitamin is vitamin K, which is involved in production of factors 2, 7, 9, 10. Therefore, when 2, 7, 9, 10 is deficient, patients will have failure of extrinsic pathway. See, complete biochemistry, complete physiology comes up here. So a failure of extrinsic pathway results in dash. Failure of extrinsic pathway results in bleeding. So what is very important to monitor this extrinsic pathway? The answer is prothrombin time. So again, another physiology, prothrombin time is the monitor for vitamin K deficiency or failure of vitamin 7, sorry, factor 7 deficiency. We call it as INR. Prothrombin time is calculated as a ratio known as INR, International Normalized Ratio. It will be normally 1. The value should be normally 1. So when the prothrombin time is elevated, patients may have bleeding disorders. And apart from that, patients will have steatorrhea because fat is not digested. So these all malabsorptions are going to happen. Therefore, the moment you see an obstructive jaundice patient, I should correct this coagulopathy, this bleeding coagulopathy, I should correct. What should I do immediately? Before even sending to other investigations, you should know, if you work in the as an oxygen in an obstructive jaundice patient, you are seeing, you will injection vitamin K, you have to put immediately. Vitamin K should be given IM for 3 days before doing any procedure. Before any procedure, you have to give vitamin K. Like any procedure means like ERCP, sphincterotomy, or any surgery, anything you are going to do, vitamin K is needed for 3 days. Sir, no, sir, I have to do emergency. I have to now do the procedure. Otherwise, patient will die. Patient will have coagulopathy. What should be given in such cases? How can I correct the extrinsic pathway immediately? So these are all the biochemistry and physiology and what all things you should know. So fresh frozen plasma, immediately you should transfuse fresh frozen plasma, which is rich in what? Rich in factor 7, 2, 7, 9, 10 is very high in fresh frozen plasma, should be infused. If you are going for any procedure, before any procedure, you should tell this. But this is very important. This is what we expect from MBBS doctors, because a patient coming to ward, you cannot just like that do any procedure. We have to make them normal by giving vitamin K injection. Is a very important drug which should be given. Vitamin K will correct this coagulopathy. Or we have to verify what is the prothrombin time before doing any procedure in obstructive jaundice patient. The key investigation that should be done is prothrombin time. Without knowing this concept, we should never go into the investigations. What all investigations done? I don't want you to remember them before knowing this. I want you to know, if I'm going to do some procedure, what should I do? First means vitamin K should be given for 3 days and verify prothrombin time. Once it is normal, then only you can do anything. No, sir, vitamin K I cannot give. I have to take for surgery immediately today itself. Immediately transfuse 5 or 6 units of FFP and correct the PT-INR. Correct PT prothrombin time INR before taking for surgery. Otherwise, you will kill the patient by causing bleeding from the surgery. Please remember, bleeding from surgery or any procedure. So now let us approach this obstructive jaundice patient. Approach for obstructive jaundice patient. So this is what I'm now going to tell is what you have to make yourself for all these topics, because protocol, I call it as approach for obstructive jaundice. I call it as protocol. What do you mean by protocol? So there is a protocol for everything what we have, what we do in life. In the morning, as soon as you wake up, you do brushing. So after brushing only you go for a tea, then only you go for some whatever you want. So that is a protocol. Like that, when you are seeing an obstructive jaundice patient, what should I do first? I will do the basic blood investigations like liver function test. Very important test needed for obstructive jaundice patient is liver function test, which will have elevated direct bilirubin than indirect bilirubin. Indirect bilirubin is elevated in medical jaundice. Direct bilirubin is elevated in obstructive jaundice. Most sensitive liver function test is increased alkaline phosphatase. Most sensitive for obstructive jaundice is alkaline phosphatase. SGOT, SGPT are all elevated in medical jaundice. That is why I'm telling you, you should read medical jaundice also along with that. There are 2 types of jaundice, medical jaundice, surgical jaundice. You should always, when we are evaluating, you have to do for both. No? So we have to do LFT. So direct bilirubin is elevated, alkaline phosphatase is elevated, and very important, you should do prothrombin time and INR, which will be elevated definitely in an obstructive jaundice case. So this is the first step. So first step is we have to do blood investigations. After doing the blood investigations, what is the next done investigation? So you do the basic blood investigations, and then you have to know whether it is a stone disease or cancer. The next done investigation is ultrasound abdomen. Ultrasound abdomen will show you whether it is a problem due to stone or it is a problem due to cancer, but it is not accurate. It will help you to go for a diagnosis. So it will help you whether it is a stone or cancer, you can derive from this ultrasound. But what is the investigation of choice for obstructive jaundice? See the questions. What is done next? Ultrasound. What is the investigation of choice? I want to know a clear-cut diagnosis. I want 95% sensitive investigation. That is MRCP, magnetic resonance cholangiopancreatography. If MRCP is showing me a stone in the bile duct, stone in CBD, MRCP is showing a stone in the CBD. What is the gold standard for next investigation? Gold standard next investigation for CBD stone is ERCP. Is not only an investigation, it is a procedure also. Endoscopic retrograde cholangiopancreatography plus sphincterotomy plus stone removal plus stenting. Double pigtail stenting is kept in the bile duct. So we have to keep a stent in the bile duct. What will I do? So if the patient MRCP picture is like this, MRCP shows there is a stone in the bile duct. So immediately what will I do next? I will do ERCP, remove the stone, and I will keep a stent like this. This is known as a double pigtail. What is pigtail? See, this is a pig. Okay, this is a pig. The pig will have a tail like this. We have a stent like this known as double pigtail stent is done. So the gold standard investigation for a CBD stone is double pigtail stenting should be done. So this is very important. So please don't forget, double pigtail stenting is done for such cases. So very important. We have to remove the stone and put a stent. So jaundice gets relieved. So jaundice gets relieved. Once jaundice gets relieved, all the problems like malabsorption, fever, everything will get resolved. So jaundice gets relieved, and electively we will plan for. So electively we will plan for, if it is a stone disease, we will plan for laparoscopic cholecystectomy. Okay, we will plan for electively, we will plan for laparoscopic cholecystectomy. So this is a protocol. So if a patient is coming to you with an obstructive jaundice, how will you proceed step by step? So this, since the common cause, what we see in Indian practice is stones, I'm telling you the protocol in the management of CBD stone protocol. This protocol is for CBD stone protocol. So you are doing an evaluation in the direct bilirubin is elevated, alkaline phosphatase is elevated, prothrombin time INR is elevated. So next done investigation shows it is a stone. So immediately I'm doing a MRCP. MRCP is showing me a stone in the CBD. Then gold standard, immediately what will I do is I will do ERCP, sphincterotomy, stone removal by keeping a stent, and I will plan later laparoscopic cholecystectomy because the stones in the gallbladder will again and again come. Always, it's a must. Laparoscopic cholecystectomy must be done. This is protocol number 1, that is for CBD stones. Okay, let me show you. These are the investigations I told you. So this is a picture showing you an ultrasound. You can see the ultrasound showing you stones. What is the finding you are seeing? This is an image-based question in NEET PG exams. What is the finding you are seeing here? A stone will cause what finding is this? You can see this is a stone. Behind the stone, you are seeing a shadow like this. This is known as posterior acoustic shadow. Posterior acoustic shadow is seen in these cases. So a stone will cause posterior acoustic shadow. So this is the first important thing. Stones will have posterior acoustic shadow. Very important image-based question for your exam. You can see this is a gallbladder having a stone. Stone is producing a posterior acoustic shadow. This question is a repeat image-based question for your exam. And then MRCP. So let me go for MRCP. This is a MRCP done. As our protocol, we have done a MRCP. The MRCP is showing you a stone in the bile duct. So what am I going to do? There is gallstone as well as stone in the bile duct. Next, I am going to do ERCP like this. So this is an ERCP investigation. I am putting a tube inside. I am putting a tube inside the duodenum using a side viewing scopy, and I am opening the sphincter and doing a sphincterotomy. So please remember that is procedure known as sphincterotomy. Let me show you what should. So this is a picture showing you ERCP showing you a stone in the bile duct, and there are multiple gallbladder stones. You are going to see a video of a. This is a picture showing you. You can see sphincterotomy we are doing, and we are removing the stones out. Can you see? We are doing ERCP sphincterotomy and removing the stones in this picture by a side viewing scopy. There's a procedure going on. The stone in the bile duct which is getting removed, and after removing the stone, you can see in this procedure, you can see using special Darmia basket. It is a Darmia basket. We are removing the stones from the bile duct. So this is very interesting. After removing the stones, you can see we have kept a stent inside the bile duct, so that for a temporarily it will drain the bile. Stent, there are many types of stents. So we have to use many types of stents are kept. This is one type of stent, like straight stent. This, what I told you before, is like this. It is known as a double pigtail stent. What you are seeing here is another stent, which is Amsterdam stent. Amsterdam stent. Some people also, if it is a cancer, they will keep a metallic stent. Permanent metallic stent also can be kept. This is self-expanding metallic stent. So when they are doing a procedure, at that time when they are seeing a cancer, they will put a self-expanding metallic stent also. There are multiple methods available. So now, this is one protocol for a gallbladder stone. So we are first case I'm discussing is a case of CBD stone. CBD stone causing obstructive jaundice. I'm discussing the protocol and the management. So in a CBD stone, I told you, you should do ultrasound, then you should do MRCP, and based on that, you should do ERCP, and we have to remove it, and we plan for laparoscopic cholecystectomy. This is the normal protocol. By chance, the medical gastroenterologists, they are failed. ERCP failed. Unable to remove the stone by ERCP. ERCP failed cases. What should I do? When they tried ERCP, it failed. Therefore, what they are going to do? They call the surgeon. They will call me for a procedure. What will I go and do? There is a stone obstructed here. The ERCP got failed. This is a gallbladder stone, and this is CBD stone. What will I do is I will open the bile duct like this vertically. I will open the bile duct, remove the stone using a special forceps known as Desjardins forceps. It's an instrument used. Desjardins forceps is available to remove the stones. It is an image-based question for your evening Viva session. Along with cholecystectomy also will be done. Cholecystectomy, CBD exploration, removal of stone, and then keeping a T-tube like this. We have to keep a T-tube like this. We have to keep a T-tube like this. So remove the gallbladder, remove the stone in the bile duct, and keep a T-tube. This is temporarily kept because we need this suture to heal. We temporarily keep this for the suture to heal. The suture will heal, and temporarily, if there is any residual stone also, we can find out later. So this is the procedure known as CBD exploration plus T-tube insertion. So this picture is what given in the next image. So this question is again a image-based question for your exam. What is this tube shown here is a T-tube. And what is this forceps shown here is this is Desjardins variety of stone removal forceps. Desjardins forceps used for stone removal. Please don't forget. So this is a surgeon's role, because as an obstructive jaundice, as a surgeon, I am discussing, I should tell you what we will do. So we will do surgical removal of stone. So you can see these are the pictures showing you the T-tube, which we kept, no, it will be kept outside the abdomen. And through the T-tube, we are pushing the contrast and seeing this procedure is known as T-tube cholangiogram. If it is normal, I will remove it. So T-tube cholangiogram is done on 7th post-op day before removing the stone. If it is normal, I will remove the stone. So there are still more discussion on T-tube complications, T-tube related. I'm not going into those topics because it is not possible to discuss all those concepts now. But remember, this is a T-tube which is kept in the bile duct. Okay, T-tube. Or sometimes some surgeons, so you can ask, sir, why are you keeping T-tube? Is there any other option? Yes, there is one another option in which when I'm opening the bile duct, if the bile duct is very much dilated, I can bring anastomosis with the nearby bowel like this. I can anastomose with the nearby bowel like a duodenum or jejunum. I can directly anastomose. This is known as CBD exploration plus choledochore, means bile duct anastomosed with the duodenum. Choledochore duodenostomy or choledochore jejunostomy can be done. In this case, there is no such problems of T-tube, etc., etc. But this is done only when the bile duct is more than 12 mm dilated. So more than 12 mm dilated bile ducts, we go for this procedure. Less than 12 mm bile duct dilated, we go for the old procedure I told you. So it all depends upon the bile duct dilatation. If it is very much dilated, we can go for a CBD exploration with the choledochore jejunostomy. You can see here I have done a bile duct anastomosed with the duodenum. This is duodenum, this is CBD. So this is known as choledochore duodenostomy also can be done. It can be done for an obstructive jaundice. If that is, nothing is possible at this point of time, patient is very sick, patient is having cholangitis, I have to relieve the obstructive jaundice now. Please remember, this is a case of stone obstructing or something obstructing below. Patient is failed ERCP. ERCP could not be done. Surgery also could not be done because patient is having a BP of 70/40, very sick patient. Patient is having severe shock. I have to remove the bile. There is another procedure. We call the radiologist who can put a stent directly like this into the liver. Same double pigtail stent can be inserted through the skin, known as percutaneous drainage. Percutaneous biliary drainage can be done for obstructive jaundice. This is known as percutaneous transhepatic biliary drainage. So this will now what it will do? It will remove all the infected bile out. Once the infection comes out, patient will recover at present. It's an emergency procedure. PTBD is an emergency procedure. That is what you are seeing here. A patient with obstructive jaundice, we have put a tube directly into the liver with the help of radiologist, and you can see the infected bile coming out. As the infected bile comes out, patient will recover. Please remember, these are all emergency procedures. So the scenario number 1 I am discussing is CBD stone causing jaundice. What will you do? So question number 1, you are telling a case of a CBD stone causing obstructive jaundice. Treatment is ERCP plus CBD stone removal followed by laparoscopic cholecystectomy is one method. So method number 1 is most commonly done method. I will remove the stone by ERCP and later I will do a laparoscopic cholecystectomy. Another method is, as I explained, I can directly operate, put an incision, choledochore lithotomy, remove the stones, keep a T-tube and remove the gallbladder also. Choledochore lithotomy with the cholecystectomy in a single sitting can also be done. So I'm telling you, you have to read latest Bailey, 28th edition Bailey. It's an extraordinary book. It explains everything in detail. Whatever I'm telling you might appear too much, but all these are there in Bailey. In fact, there are more points than what I'm discussing in Bailey. You have to read Bailey. So all these points are there in Bailey. So what is this? This is an T-tube, and you can see a picture showing you a T-tube cholangiogram, which is done showing you a mist stone. All these are different topics. So mist stone in a T-tube cholangiogram. All these things will be discussed. So another question, scenario number 2 is, I told you when there is a scar, post-cholecystectomy biliary stricture. So the surgeon has done a gallbladder surgery, and during that time he injured the bile duct that caused leak, and now it has settled with the formation of a stricture. So a stricture means what? Bile cannot flow further. So what should I do? Now electively, I will do a procedure known as bringing a jejunum and anastomosing with this bile duct known as hepatico-jejunostomy using a rule limb. See, I hope you will read rule limb from stomach chapter. So this is a rule limb of jejunum which is brought. That limb will be anastomosed with the normal bile duct. So this procedure is hepatico-jejunostomy, that is for post-cholecystectomy biliary stricture causing jaundice. So each case you should know what should be done. So a CBD stone, what should be done? Biliary stricture causing jaundice, what you should do? Scenario number 3 is definitely a MCQ for your exam as well as a clinical topic, that is cancer in the distal pancreas. So with this cancer in the distal pancreas, I will complete the topic. So this is a bile duct and this is periampullary cancer, and this is pancreas. In a pancreas, you can get a cancer in the head of pancreas. So this is another cancer, or in a distal bile duct cancer. See, 3 cancers I have discussed here. Distal bile duct cancer, pancreatic head cancer, head of pancreas cancer. Then third one is periampullary cancer. These are the 3 cancers which can cause enlarged gallbladder like this, with an obstructive jaundice like this. So the enlarged gallbladder with an obstructive jaundice is seen in these 3 cancers. So what is the treatment for these 3 cancers? All the 3 cancers, the treatment is pancreatico-duodenectomy. The procedure name is known as Whipple's operation. Please remember Whipple's operation. So you will be asked about Whipple's operation. What is Whipple's operation? What are the structures removed? What are the complications of this operation? Where will you do? First question I have answered. Where will you do Whipple's operation? In a distal CBD cancer, in a head of pancreas cancer, in a periampullary cancer. In these 3 cancers, I'm going to do Whipple's. What is Whipple's? You should understand. So Whipple's operation is one of the dream surgeries of gastrosurgeons. We always love to do this surgery. Please understand the anatomy. So you can also you should actually ask one question now, sir, why are you removing duodenum when there is a cancer in the pancreas? The problem is in the pancreas. Why are you removing the duodenum? You should ask me this question. The answer is very simple. The duodenum as well as pancreas, they both are romantic organs. They are inseparable. They always have common blood flow, common lymphatic drainage, etc., etc. Therefore, I should remove the pancreas along with the C part of duodenum. Okay, what is this vein? This vein enters the neck of pancreas known as superior mesenteric vein. It joins with the splenic vein and forms portal vein. This is known as portal vein. So this tunnel is known as tunnel of love. This tunnel is known as tunnel of love. Please remember. So if there is a cancer in the distal bile duct, pancreatic head or periampulla, I am going to do one operation known as Whipple's operation, in which I am going to remove the following structures. What are all structures removed in Whipple's? I will cut the stomach here. Distal gastrectomy. So distal gastrectomy. Entire duodenum. I will remove the entire duodenum up to D1, D2, D3, D4, up to the ligament of treats. I should cut and remove the entire duodenum. In pancreas, up to where I will cut? Up to the tunnel of love. That is why we call that. We call it as tunnel of love because we love the cancer should not infiltrate into the tunnel of love so that I can easily remove the head of pancreas. Okay, and I should remove the bile duct, gallbladder and the bile duct will be removed. So these all are removed and finally the anatomy will be like this. This is the bile duct and this is the stomach and this is the jejunum. This is the jejunum. And this is the pancreas. This is the remaining part of pancreas. So now this is the remaining anatomy after surgery. So what should I do? Now what will I do is, I will bring this jejunum. I will bring this jejunum and anastomose with all these 3 structures like this. So like this, I have to anastomose with them. Gastrojejunostomy, hepatico-jejunostomy, and we have to also anastomose with the pancreatico-jejunostomy, PJ. So 3 anastomoses will be done. So there are 3 anastomoses which will be done after Whipple's. The first done is pancreatico-jejunostomy, second done is hepatico-jejunostomy, Third done is gastrojejunostomy. This is the completion of this procedure. PJ, HJ, GJ will be done. So the procedure done for these cases is after Whipple's is PJ, HJ, and GJ are done for the patient. So this is known as Whipple's operation. The most common cause of death in this operation is PJ anastomotic leak. Leak happening from here. PJ anastomotic leak is the most common cause of death. Is the most common cause of death. So you should read about Whipple's operation and its various complications from Bailey and Love. So it is very important topic from Bailey and Love. So if it is a distal CBD, periampullary, head of pancreas, you should go for Whipple's operation. And pancreatic cancer, if you suspect. So in your history, if you suspect pancreatic cancer, I told you, in obstructive jaundice, what is the protocol for pancreatic cancer? Pancreatic cancer protocol. Like a periampullary, whatever it is, pancreatic cancer protocol is same. Everything is same. You are doing the liver function test. Liver function test is elevated bilirubin. You have to do prothrombin time. INR will be done. It will be elevated. Very, very important. You should do one tumor marker. What is the tumor marker for pancreatic cancer? Very important. MCQ CA19-9. CA19-9 will be elevated. Will be also evaluated. CA99 is elevated. And when you first investigation, what we do is always, what is the next done investigation is always ultrasound. Ultrasound abdomen is not sensitive for pancreatic cancer, but it will give a clue. There is a lesion in the pancreatic, like that, it will give a clue. But what is the investigation of choice for pancreatic cancer? So this is where a clinician plays a major role, because if you are just going to mug up, you cannot understand the concepts. You have to understand and read the disease. You have to see a disease in your ward. When you go for the ward, there is a pancreatic cancer. Go and see what all investigations done for them. So for pancreatic cancer, investigation of choice is CECT abdomen, which is with a pancreatic protocol. Pancreatic protocol CT abdomen means what? Means we have to take a CT cut at every 2 mm to 3 mm. We have to cut the pancreas and see. So we have to see the pancreas at 2 to 3 mm cut. And based on that, we will see whether it is a pancreatic cancer, whether it is operable or inoperable or borderline resectable. That is a term newly introduced in 28th edition for you. So finally, students, you should know about what is borderline resectable pancreatic cancer can be detected on CT scan. What is borderline resectable cancer? Please remember, this is pancreas. This is the portal vein. Please don't forget, this is portal vein. And this is superior mesenteric artery. This is superior mesenteric artery. If there is a cancer in the pancreas, if it is infiltrating, please remember, borderline resectable is infiltrating superior mesenteric vein or portal vein more than 180 degree. So the tumor is infiltrating portal vein or SMV like this, more than 180 degree, or infiltrating superior mesenteric artery less than 180 degree. It is said to be borderline resectable cancers. So superior mesenteric artery less than 180 degree, superior mesenteric vein or portal vein more than 180 degree is called as borderline resectable. You can find it out by CT scan. Such borderline resectable cancers will go for neoadjuvant chemotherapy before Whipple's. So neoadjuvant chemotherapy will be given for them before doing Whipple's operation. So CT abdomen plays a very major role in finding out whether the cancer is operable or inoperable. Please remember, should I take a biopsy before surgery? Is it mandatory in a pancreatic cancer? Biopsy, is it must? Very important point I want to tell you, especially those who are final years here, you should note this point, very important for your exam. There are some cancers which doesn't need biopsy. In fact, you cannot take biopsy. One of the cancer is pancreatic cancer. Pancreatic cancer biopsy is not mandatory. We can operate directly based on the CT imaging findings. Number one, HCC, hepatocellular cancer, we can operate without taking biopsy. RCC, renal cancer, you can operate without taking biopsy. Okay. Number 4, gallbladder cancer. In all these cancers, biopsy is not needed. So biopsy is must means no, not needed in which cases? In all these cases, no need of biopsy. So you can wonder, sir, how can we operate thinking it as a cancer? There are all these cancers are diagnosed based on radiological investigations. No need of help of pathologist. Radiological investigations are enough. No, sir, I will not operate. I'm having so much of doubt. I cannot operate directly the pancreatic cancer. I want tissue. I want tissue means what will you go for? You should go for EUS guided FNAC is the investigation of choice to take biopsy. If you want to take biopsy from a pancreatic cancer, the only advised method is EUS guided FNAC. Otherwise, you should not take biopsy in a pancreatic cancer like a CT guided or percutaneous. If you take, you will disseminate the tumor, it becomes inoperable. Another important place where biopsy should not be taken is testicular cancers. I hope you will be seeing this and reading this in cancer topic. So testicular cancer, you should not take a transscrotal biopsy. I cannot explain this at this point of time, but please remember. So where all biopsy should not be done or not needed is testicular cancer, gallbladder cancer, RCC, HCC, pancreatic cancer, all these cases, you should not need biopsy. If at all you want to do biopsy, there are many methods of doing biopsy. One of the methods for pancreatic cancer is EUS guided FNAC. So that should be done. So pancreatic protocol CT, you can see this is a CT scan showing you all should know how to read and identify the CT scan picture. So this is a picture showing you pancreas. See, this is a pancreas, the duct is dilated. This is a bile duct which is dilated, gallbladder, like that. You can see a pancreatic lesions, periampullary lesions can be diagnosed. MRCP also can show you the lesion, but it is not the investigation of choice. Investigation of choice is CT scan. So this is a picture showing you double duct sign. In an ERCP, you can, if you do in a pancreatic cancer, you can see the two ducts separately seen, known as double duct sign is seen on ERCP. So this is another rare cases. Reverse 3 sign is seen in periampullary cancer. Olden days picture. This nobody is doing nowadays. Epsilon sign. This is known as epsilon sign. These are all just for completion's sake. Otherwise, they won't ask you these things. They won't ask you like memorizing questions and all. They won't ask you. They will ask you only the concepts, how to diagnose, how to manage, what are the complications expected. Like that only the questions will come. So this is a picture showing you a Whipple's being done. You can see the portal vein and the SMV, which is separated and very carefully preserved. If there is a portal vein invasion, you can see the portal vein can be resected and anastomosed. You can see this picture showing you portal vein resection and anastomosis being done. So this is a specimen of Whipple. So what is the specimen of this image-based question is a last year NEET PG question. So what is the specimen shown here is a Whipple specimen. This is a Whipple specimen. So you can see the entire duodenum, pancreatic head is there, bile duct with the gallbladder, all those things will be there. It is a specimen of Whipple's. All these are various cases operated by our department. So this is a picture showing you 3 reconstructions. I told you, PJ, HJ, then GJ. All these operations will be done. So all these things are a little extensive. So just remember the points I told you. The last scenario, if it is a bile duct cancer, the bile duct cancer, please remember, if the cancer is there in the bile duct, what should I do? I should resect the bile duct with a margin of 1 centimeter. I should resect and I should do a hepatico-jejunostomy. So I should resect the cancer, bile duct cancer with 1 centimeter margin and I should do a hepatico-jejunostomy. So there is a classification of hilar cholangiocarcinomas known as bismuth correlate classification. This again a question from Bailey and Lau. Bismuth correlate classification of hilar cancers. Away from the hilum is type 1. At the hilum is type 2. Involving right duct is type 3A. Involving left duct is 3B. Involving both ducts is type 4. This is bismuth correlate classification. Whatever it is, we have to give a margin of 1 centimeter and many of these patients will need hepatectomy. So remember this for your exam. So these are rare scenarios. You can see this is a picture showing you a Ascaris worm in the ERCP causing obstruction. You can see when we are doing ERCP, the Ascaris worm itself is coming out, the obstructed in the bile duct. You can see we are removing the Ascaris worms. So Ascaris worms can cause obstruction of the bile duct. Hydatid cyst, that can rupture from the liver and they can occupy the bile duct. So these are some of the image spotters. What is this syndrome? I hope most of you will not be able to identify this, but you know the syndrome. This is known as Mirici syndrome. What is Mirici? Mirici is a stone in the gallbladder, is very big, compressing the bile duct. So GB stone compressing bile duct. GB stone compressing bile duct causing obstructive jaundice is known as Mirici syndrome. Very important. First point. This is a picture second showing you a Mirici syndrome with the fistula being formed here. It is a picture of Mirici syndrome. And this is a picture showing you ERCP showing the MRCP showing you a sign known as, what is the name of this sign? This is known as meniscus sign. Meniscus sign is a feature of CBD stone. There is a stone in the bile duct that is known as meniscus sign. This investigation is T-tube cholangiogram showing you meniscus sign. Okay. So this is another picture showing you CT scan of the gallbladder showing you there is a sign. What is this sign? This is known as Mercedes-Benz sign. Add in the gallbladder known as Mercedes-Benz sign. Okay. So with a warm regards from our coaching institute, our next institute, we thank you all for giving the opportunity, and this completes. And if you want, you can follow my YouTube channel. Most of these videos already there in my channel, YouTube channel Rajamahendran, and you can follow me on Instagram, either in my Facebook or Instagram under the name Surgery Sixer. You can find out my videos. Everything will be available there. So I think let me ask any doubts.
Thank you for this wonderful session. So we are also joined by Dr. Abul Hassan sir, a well-acclaimed pediatric surgeon from Erode. He's the chairperson of IMA JDN Tamil Nadu and also state president.
Hello, sir.
So I'd like to call him to
Hello.
give few words, sir.
Sir, good evening, sir.
Good evening, Rajamahendran. How are you?
Fine, sir. Fine, sir. I think you are
I
the
was-
OT.
Yeah. But I was hearing your this thing. Very,
Thank you.
very nice to hear our UG days teaching. So nice.
Common topic for
So-
UG students.
So repeatedly, repeating very important thing is, important triads and symptoms. Signs is very nice, very nice. Thank you, sir.
Thank you,
Our
sir.
JDN is organizing. Already we had met in another occasion like.
Yeah, we've done another session,
Yeah.
so
Yeah. Definitely, there is so much of scope for this kind of seminar. Sky is the limit. Anyway, very happy that next year, I will be the president also. We'll see much more advancement in this thing. I am very thankful to Praveen and my boys, a team of very enthusiastic staffs doing this kind of academic work. Very nice. Thank you very much for
Thank you, sir. Thank you so
enlightening
much, sir.
about
Thank you,
our
sir.
obstructive jaundice. Very nice, sir. Very nice. Thank you very much.
Thank you, sir. Thank you for providing
Thank
me the opportunity, sir. Thank you, sir.
Okay, bye.
Thank you so much, sir. Thank you so much, sir.
Thank you.
Okay,
for-
Brian. Okay.
Thank you all. Thank you all. Thank you all for the session. Thank you so much.
Thank you, sir.
Thank you. Shall I
We'll
leave?
we'll have a small vote of thanks, sir.
Sir, we have a vote of thanks by Shalin, sir.
Yeah, please. Please.
Yeah, Shalin. Now I would like to hand over to Shalin, sir.
Yeah.
Yes, sir. Thank you, sir. That was an amazing session. It was a pleasure hosting you, sir. We hope that the listeners got to learn a lot on this topic, and we'd like to have you with us on many more topics, sir.
Thank you.
I'd like to extend my heartfelt thanks to Dr. Rajamahendran, sir, for accepting the invite amidst his hectic schedule and enlightening us with his knowledge. I would also like to extend my gratitude and thanks to Dr. Abul Hassan, sir, Dr. Venkatesh Karthikeyan, sir, and Praveen, sir, for providing me this wonderful opportunity to conduct the webinar. I also thank ClearNet for looking after all the technical aspects of the session and the delegates for attending the session. The recorded session will be uploaded in the YouTube channels of IMA JDN and SNO Tamilnadu in a week, and the e-certificates will be provided to all the registered participants in a couple of days. Follow our Instagram and YouTube handles at SNO Tamilnadu for regular updates and webinars. Thank you everyone for joining us for this session. Thank you so much, sir.
Thank you. Thank you, Praveen. Thank you.
Thank you so much, sir. Thank you so much.
Sir.
Thank you everyone for sharing their valuable insights. We are more than grateful to everyone present here. We hope to have you again on our platform very soon for our next session. With all your permission, we are closing the session over here.
Yeah, you can keep the session.
Okay, thank you so much. Thank you so much, everyone.